I'd like to invite Melissa Mariñelarena. I said it right this time. Melissa is the founding partner of Clinician-Driven Quality Solutions. She provides expertise on the development, evaluation, and potential national quality forum endorsement of quality measures to various stakeholders. Prior, Melissa worked at NQF, the National Quality Forum, which is, if those of you who are unfamiliar with the National Quality Forum, it's the nation's leading most quality organization in the country. NQF, National Quality Forum, they don't develop measures. They get measures that are submitted to them from different organizations, quality measures like in a hospital or elsewhere, and they go through this super rigorous process, with multiple committees that evaluate those measures. Only NQF measures that are only NQF endorsed measures are picked up by CMS. So that is really the level of rigor. And Melissa was in charge of all of the hospital quality measures. So she had a huge team underneath her, and she's done some consulting work for us. She used to fly in from DC and kind of help us try to figure out quality when we first got the RAND 2.0 study, because we wanted to go to best quality at best price and really didn't understand quality. So we've learned so much from her and continue to do so. So please join me in welcoming Melissa.
Thank you, Gloria. I am so excited to be here. I was very lucky that I accidentally met Gloria when I was at NQF and have been able to work with her over the years, and I'm happy to be back in Indiana after, about 3 years or so. So as Gloria said, my background is in quality. So I am going to make the conversation today that you've been having even more complex, because unfortunately quality is not as clear-cut as cost and price. Here we go. So I know a lot of you may be familiar with the CMS Star Ratings program. Those are, it is part of what is publicly reported on the CARE, they now call it the CARE Compare websites. There's one for different sectors of healthcare. Hospital is the original one. There's one for nursing homes. There's Physician Compare, and we're focusing on the Hospital Compare right now, or what used to be hospital. And they have the short-term acute care hospitals. CMS also branches out and looks at long-term acute care hospitals, inpatient rehab facilities. So they have a whole bunch of measures and payment and policy programs for different facilities, including ambulatory surgical care, which is separated, which was interesting when Chris was talking about that, because CMS has their own definition of ASCs. And the measures sometimes overlap. So most hospitals are required to participate, and if they don't, there is some penalty in their payment reduction every year. And then it depends on the type of program and the measure of where they're at, whether it's just publicly reporting the information, and then it gets into, as the measure matures in the program, then it gets into the penalty programs, where that's the hospital value-based purchasing program. So different measures can be in various programs at different stages of maturity through their program. And so it's some of those measures in this huge portfolio of about 100 measures that are used to calculate the CMS star ratings. And I'm just going to give you an overview. So some of the quality measures that are used in this program are process of care measures, outcome measures, and then patient experience of care. So the process of care measures are just that, capturing whether something was done. And those are the original measures. You could take it back a little bit further and talk about structural measures. Those are even sort of lower bar measures. Outcome measures, I always had to remind myself and everybody around the table at NQF that outcome measures are measuring patient outcomes, not nursing outcomes, not physician outcomes, not hospital outcomes, it's patient outcomes. And then the patient experience of care is near and dear to everybody's heart, HCAHPS, and that is a survey that it consists of several different measures. That's what we call it, in my world, and I will show you the questions. And that's probably the one that's most relevant to what patients actually care about. Some of them are, was it noisy at night? Did they answer all of my questions? Versus the other measures that are very complex, and you're talking about 30-day mortality rates, and I don't know that most patients are looking at that specifically. So this is just a quick history of hospital public reporting. Back in 2005, started off with 10 measures. Right now, there's a total of about 100 or so eligible measures. Most hospitals, on average, will report about 37. And that's because there's different reasons why they have to have enough patients, enough case counts in order to be able to report. So a lot of times, if you go onto Hospital Compare, you'll see like an NA, and that's because they didn't have enough cases to be able to report. And if you go even further, that has to do with the reliability and the validity of the measure. And I could do a whole day on all of that, which I did used to do when I was at NQF. But anyway, just a quick timeline of where we were back in 2005. Into where we are now. Most recently they just consolidated all of the measures, but you could see the lifeline of public reporting where we started. Then they added the patient experience of care, the mortality measures included outpatient and emergency department. Then there was the readmissions measures, the HAIs, the healthcare associated infections measures. And then they started into penalizing hospitals with the readmissions reduction program, and then the hospital value-based purchasing program that I talked about. So this is just a quick overview of the different categories that are used for calculating the star ratings. CMS looks at mortality, safety of care, readmissions, patient experience, and timely and effective care. And then I'm going to share. So within how they calculate the star rating itself is very complex. There's a whole methodology on that. It's all accessible. This is all public information. The thing that has changed most recently is the weighting in the calculation. So everything is weighted 22%. Minus timely and effective care. I think what's important to note is that when hospitals' ratings change over time, it could be because the weighting in the way it was calculated has also changed over time. May not actually have anything to do with the quality being better or worse. It's just that the methodology has changed. Another thing is if a hospital does not have enough case counts to submit a measure, then for a certain measure group, then that percentage gets pulled into the other ones. So some hospitals, may have more readmission data and not enough timely and effective care. Timely and effective care seems to be more around emergency department and outpatient procedures. So all of that can impact the star rating. Gloria called it peeling the onion. I'm a former ICU nurse. I call it looking under the covers. So I want to pull back the covers. I want to see what's under there. So when CMS looks at mortality, they're looking at mortality after heart attack, CABG surgery, COPD, heart failure, pneumonia, stroke, and serious treatable complications after surgery. I just wanted to note that that is a composite measure, which is just one measure made up of a whole bunch of different measures. I think within those complications, there's about 7 of them. So it's looking at 7 different complications, and then it bundles it all up in a very complicated way and gives you this measure. But that's what it's looking at for mortality. And I'm not going to go in detail into all of these. It was just sort of give you a snapshot of what is on there. This is how CMS defines safety of care. So these are your healthcare associated infections. And there are more coming that they're going to be adding. If you follow the pre-rulemaking process and the federal rule that gets published, they are adding on some more. There were some that were just reviewed this year. But anyway, so here are your safety of care measures. Your readmission measures match your mortality measures. So heart attack, CABG, COPD, heart failure. This one has hip and knee surgery, pneumonia, And then we also have some unplanned hospital visits after outpatient colonoscopy. So, you're not supposed to end up in the hospital if you've had an outpatient procedure. And these are all outcome measures. This is just small on purpose. So timely and effective care. These are mostly, I believe, all process measures. A lot of these are very old. They're some of the original ones. They are capturing outpatient, emergency department, but this is how quality is defined as of right now. A favorite one of hospitals is severe sepsis and septic shock. Yeah, that's a favorite one. That's also a process measure. It is not an outcome measure. So people there's always the argument of process versus outcome measures. Process measures improve because the care is actually improving, or is it the documentation that's actually improving, right? And then there's the argument for outcome measures, because if you're doing what you're supposed to be doing, then the outcomes will improve. But right now, there is no sepsis outcome measure that is in the CMS program. So a lot of process measures here that have been around for a very long time. They all are NQF endorsed. And for hospital programs, CMS does prefer to have NQF endorsed measures. When you get into the clinician or physician programs, those do not have to be NQF endorsed. So very different process for the two measures, or for the two different programs. Everyone's favorite, patient experience. So here are the different components of the patient experience measure. It's a survey, it's validated, it's tested for reliability, it goes before NQF, ideally for maintenance every 3 years or so. There's probably, and recently on the star rating for the different hospitals, CMS pulled the two apart. So there's an overall star rating, and then there's the patient experience of care star rating. And it's interesting, if you go and you look, sometimes there is no relationship between the two. You can have like lower quality scores on your overall hospital, then your patient experience is very high, or the other way around. So it was good that they pulled the two apart, because one or the other could have been covering up the performance on one. So these are some things that I want everyone to consider, that when you're looking at measures, and especially the CMS measures, there's various data collection periods. It was already confusing. COVID did not help. Right now, there's been a delay in some of the data collection and reporting. But even before COVID, some of them may be collected in a January. The year may start in January, the other one may be in July, some may be 2 years, some may be 3 years. And all of that depends on when the measure went into the program. And it could also, they're collecting time period overall, whether it's a year, some could be 3 years, and maybe not necessarily CMS, but there are other reporting programs. And that's because they need to have, it took that long for them to get that much data to have a reliable and valid quality measure. So consider all of that it's kind of all over the place. The data is also, a lot of complaint from hospitals is that the data is old, right? So right now we're looking at 2019 data that's going to be 2020 data that's going to be posted on the website. So some hospitals will have their own dashboards. I worked at a large hospital system in LA years ago. They had their own dashboard. Now, then you also have to question their measures, because any internal measure is not going to go through the NQF process. At NQF, we looked at the evidence, the performance gap, we look at reliability, validity, there was a whole criteria. So you need to think about that. Different data sources. The measures on the CMS website all have different data sources. Some of them are claims measures, most of them are claims-based measures. So those are going to be your Medicare population, your 65 and over. There are some that are specified for 55 and older. Then you have your all-payer, and those are usually submitted by the facility manually. Those will be 18 and over. Sepsis includes everybody. So the data that you see on CMS website for sepsis is 18 and over for all admissions. There's a maternal one, so that's not going to be your Medicare population for the most part, right? So that's C-section. I think it's like 2 weeks early. So that is also submitted by the hospital. They also will do some other process measures that are either submitted electronically, but again, so those will be your all payer. It's the main claims-based measures that are CMS, because that's the one that they could get their hands on. So when you look at a hospital that has a huge Medicare population as their payer, then their CMS measures or their quality star ratings probably make sense, right? And again, the detailed measure specifications, looking at the data collection period, the age, and the data sources that you're using to collect the information. And that's it.
Thank you, Melissa. Now you can see why quality is so complex. I mean, I barely got half of that. So it's critical because we all want to go to best quality, right? Nobody wants to go to the cheapest place and come out dead. So we need to understand quality. We need to really spend time with it. It is complex. Thankfully, there are folks like Melissa that understand it at a super granular level. And the star rating that we have on Sage Transparency has all this stuff. So all these measures that she was talking about, it's kind of all rolled up into a star rating, which is really nice. You can go on CMS's website and open up the star rating and see the 5 domains and open up each domain and see all the measures. So you can do a deep dive on your own as you wish. In our private report, we'll have that information for folks upon request as well.